The project that I've just finished working on and we're using BMJ Quality to publish is the care home project. We know that residents in care homes take a lot of medicines. We know that some of the medicines that they take are unnecessary and some are inappropriate and some are actually quite harmful. And we came across this when we met a care home resident who was on lots of tablets but actually didn't need any of them. And as a result, we pulled together a team and developed a project where we would optimise medicines in older patients and not only do that but also involve those residents in decisions about the medicines. We bid for some funding from the Health Foundation, got the funding and ran it over a year. And actually what we found was that about 2/3 of residents across 20 care homes that we tested our project in were taking medicines that didn't actually need. So we went and worked with GPs and consultants to actually stop some of those drugs and found that we could reduce the pill burden with these patients by 17%. We had a fantastic team comprising of clinical pharmacists, prescribing pharmacists, we had a consultant old age psychiatrist, we had GPs, we had care home nurses, the palliative care team were involved, and then we had non-clinical teams like the patient experience team, we had communications, and we had representatives from the primary care trusts at the time. So it was a massive team and it worked really well. There was challenges, but it was very important to get the team right because we needed members. We needed the team to represent every aspect of the project. So we needed top-level support from my trust. So we had a member of the executive management team, Annie, who was there to give us that support. But equally, we needed the coalface GPs to be on board as well. So we needed GP representation. And the challenges were that if you ask a big team a series of questions, you get a series of answers back, and it was trying to keep everybody happy, but at the same time ensuring that the project didn't lose focus. One of the early sort of pieces of learning we found was that everybody works differently, and it's very difficult to create a model of working. But what we did find was through sort of rapid testing was that we actually found sort of 4 very simple models that we could apply to across the board. So that was good. So we didn't have to come up with hundreds of different ways of working. 4 models seemed to fit everyone's a vast diverse range of people's ways of working. We didn't do this project to save money. There was never an intention as a cost-saving project because it was more about the quality of the patient. But we found that vast amounts of money money from prescribing was released. So overall we saved about £83,000 by stopping about 700 medicines. So that was actually quite nice to see. I've got 2 slightly different experiences with BMJ Quality. First is the Shine project with care homes, which was a retrospective addition of data, and then the other one is using the tool from the beginning of the project. So with the Shine project, I was impressed how it was laid out. It was nice and easily to fill in the sections. It sort of made you think about each aspect of the project, what tools you used, what measurements you made, your reflections, and that was nice. And I thought to myself at the time, it would have been nice to have that at the beginning of our project. When we started doing the self-administration of medicines project, which is really complicated, we've tried to do it before, we just can't get it to work, which is letting patients take their own medicines in hospital. So this time around, we're going to apply a QI methodology to it. We're going to take it step by step and try and work out what the issues are and deal with those issues. And the BMJ Quality structure is fantastic. So it's in the first section, I've been working with my colleague Anne, and we've just been populating the various bits of the section. It's really made us think about what we need to do, who we need to speak to, create our team, the people we need to get buy-in from, and we did that, and then we moved on to section 2 as we started doing the project, as we went live on the wards implementing the project. And it's just a useful place to keep your thoughts together. You come across new literature, you can add it there, and to me, although we're not there yet, the best thing about it will be that at the end of the project we build in the publication as a part of the whole project, and we're not having to worry about that as a separate thing. And it's completely differently to the way we've always worked. We've done work, and then we've sort of sat down and thought about publication. And sometimes that doesn't happen because we don't have the time to do it. One of the issues with quality improvement in small audit projects is even small research projects. Journals aren't interested in small projects like that. And sometimes what you've got is actually a very useful piece of work that you'd like to share, but it isn't of the research robustness of a bigger study, so it's very difficult to publish. I've just published a small paper on pharmacists prescribing. It's taken me a year to do so and 4 sets of reviews, and things like that just put people off, I think. Whereas I think the BMJ Quality improvement process, where you build in the publication and the dissemination and the learning from the start of the project, is really important.